evening, and welcome to our educational webinar on Lapiplasty 3D bunion correction. We appreciate you joining us. I'm Derek Pease, the manager of digital marketing at Treace Medical Concepts. Treace Medical is the company who patented the Lapiplasty procedure and manufactures its instrumentation and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is a decision that isn't taken lightly. We applaud you for empowering yourselves with information to make the best informed treatment decision you can. I'll quickly get a couple of housekeeping items out of the way, and then we can get right into the presentation by our surgeon speaker, Dr. Ramon Rodriguez of Mobile, Alabama. First of all, you're all listening to the webinar on mute, but you can ask questions throughout by clicking on the questions tab in your control bar and typing them in. We'll be answering questions sprinkled throughout the presentation and at its end. We'll also be emailing you all out an archived link of this presentation to refer back to within just a few days. Lastly, I know that you'll enjoy our surgeon speaker, Dr. Rodriguez. But if you're attending outside of the area, you can find locally trained Lapiplasty surgeons in your own area to consult with by visiting our patient website, lapiplasty.com, where you'll find a prominent Find a Doctor button at the top of the homepage, searchable by zip code. Now we'll start to introduce tonight's surgeon speaker, Dr. Rodriguez. Dr. Rodriguez served in the Dr. Rodriguez was the director of the foot and ankle division in orthopedics at Tulane University for over 10 plus years. He had a fellowship with the Foot and Ankle Surgery Fellowship of the American Sports and Medicine Institute in Birmingham, Alabama, a fellowship with the Orthopedic Surgery Residency at the University of South Alabama in Mobile, Alabama. And his other education includes Louisiana State University of Medicine in New Orleans, Louisiana, pre-medical at the University of New Orleans, Louisiana, as well as Tulane University in New Orleans, Louisiana. One reminder about and so with that being said, I would now like to introduce you, and I will hand it over to Dr. Rodriguez, who will take us through tonight's presentation, and I'll return at the end, as I mentioned, to moderate a question and answer segment. Dr. Rodriguez, the floor is yours.
Thank you very much, Derek. Yes, welcome everybody. Appreciate y'all taking your time out this evening. So a few of the history here. Lapiplasty is, it's not investigational. This is a FDA cleared surgery since 2015. Now, Lapidus in itself is not a new concept. The Lapiplasty system has figured out helped make a Lapidus surgery more as an instrumented operation and has made it more reproducible for the surgeon. And they've given us the ability to do this with cutting guides, which has been revolutionary. And it's manufactured by Treace Medical Concepts. The surgeons who are eligible, you have to go to a training course first, and there's been over 90,000 Lapiplasty procedures done. Yes, it is covered by most insurances. Now, Medicare costs and coverages vary, and you have to check with your provider to see how it is covered in your area. We are, again, to find somebody, as Derek mentioned earlier, you can go to the Lapiplasty website and put your zip code, and they can direct you to a Lapiplasty surgeon in your area. Now, as in any surgery in the foot and ankle or anywhere on the body, there are risks of whether things heal. So metal is being used, metal is being put in the body. We are so we have all of the risks of any type of surgery. So infection, you can have pain from the incisions, you can have a reaction to the metal. The implants, there's always a race whenever you put metal in somebody to do, in particular, fusion like this, there's a race between the body healing and the metal breaking. Now, this is there's some unique properties of this surgery. where we use locking screws in a 90-90 configuration, which really is a very strong construct. Now, of course, bone has, some people have weaker bone than others, and so there are risks on how the body will respond to instrumentation in the foot. There can be some loss of reduction, and you can develop non-unions, but again, with the 90-90 locked construct, that really mitigates that as a possibility. And then there are, this stress shielding means that due to some bone density and the strength of this, the bone can stress shield, where the implant can make the bone weaker. And then you can have, anywhere you have a bony prominence, the body will lay a bursa, so you can get some bursitis. So the old adage was that bunions were just a bump and that you could just shave it off. And this is, there bunions come in many different flavors, but this is really not proven to be true. Now, bunions do cause pain, they can cause swelling, and you can get pressure and numbness in the area. And then you get crossover of the great toe onto the second. So you really just can't, it's more of a rotational deformity in the metatarsal. And so what they have figured out is that some of the newer concepts that we're talking about on bunions is that the metatarsal is really not crooked. It is the bone is actually straight. And what we're seeing is that the bunion is really coming from an instability of the bone in the joint. Like, it's not of the bone, it's an instability of the joint, which is causing it to spin, which in turn causes the metatarsal to deviate to the inside, and then your big toe will deviate to the outside. And then when the big toe extensor tendon gets past the center of rotation of the metatarsal head, it can propagate the bunion at a greater clip. And and then you get uncoverage of the sesamoids, which are the two lever arm bones underneath the big toe, and they get uncovered, and the bone, because the big toe is coming to the inside, those bones are actually staying where they were supposed to because they're held in by a tendon. Now, people, ask me all the time, well, where did my bunion come from? Well, ask your mama and your daddy, because there's a very much of a genetic predisposition. Now, there are some old thoughts that societies that didn't wear shoes had less of an incidence of bunions, and that may or may not be true, but there is certainly a genetic predisposition to the bunion. Now, so if we look at this diagram, the bunion's really not a 2D, two-dimensional problem. It's a rotational. So correcting the bunion here by just, in the traditional chevron osteotomy, was basically cutting the bone and shifting it over, but that doesn't account for the rotational component to the bunion. And again, we're talking about the unstable foundation at the base of what's called the tarsal metatarsal articulation of the first TMT joint. So the old distal chevron osteotomy was cutting the bone, shifting it over, but it did not correct any of the 3D architecture of the bone. Now, non-surgical options that you can do orthotics and inserts, you can do toe spacers, and you can do splints. Now, the night resting splint, which is in this picture here, cannot be worn at night during the day. So it does help as it's a stretcher, and it can help, but it does not solve the problem during the day. You cannot use it during the day. So how does this surgery work? Well, we put the patient and we do our preparation of the joint, and basically the system allows the doctor to put a guide in order to cut the bones, and it makes a bunion more like a total knee arthroplasty and very reproducible in its steps. And then you have this compressor device that we will dial it in, and we'll put a pin and derotate the metatarsal, and that allows us to restore the anatomy. And then we'll take provisional x-rays throughout the procedure. And and then there are other steps where we do our soft tissue releases, and there's some augmented operations, parts of this operation that may be where we do some additional osteotomies of the great toe proximal phalanx, called an Aiken. And oftentimes we do a bone graft from the heel in conjunction with the Lapiplasty procedure. So how do we determine whether the patient's a good candidate? I mean, I think that is a question that you need a consultation. We'll evaluate a patient. When I was starting in my practice and residency, there was a concept about hypermobility. Well, I think the hypermobility is truly that the metatarsal gets to be unconstrained by the other soft tissues in the foot, and the big toe becomes more like a thumb, and as the base of the first metatarsal becomes more oblique, the metatarsal becomes more unconstrained, and that allows the toe to really spin out a little bit more. So x-rays would certainly have to be done, and for anybody to be evaluated and an examination to be done. And as far as can a Lapiplasty be done with having had a prior bunion, certainly it would make the operation more difficult. But I think that's a question that you need to, we can always have this as an idea of what we can do as a Lapidus can be the operation, the Lapiplasty, excuse me, can be an opportunity. We can, what I find in my practice is I'm actually applying this technology to other conditions, not just the bunions. I've applied it to arthritis and have had nice, good results, and have had some midfoot reconstructions that have been remarkable. And so I've been very pleased about it. Again, the procedure itself helps correct the deformity in multiple planes, and that's really, it's a 3D reconstruction, and I really find that that's very helpful. And again, it does address that it's focusing the operation at the root cause, which is at the base of the first metatarsal, in that it's a spin. Now, the post-op protocol for this, typically we will keep a person off of it for the first 2 weeks in a post-operative splint, and then we will allow them to weight bear in a boot for the next month, and then they will begin to migrate out of the boot into their regular shoe wear anywhere between 6 and 8 weeks, and they'll be getting back to activities around that 3 to 4 month interval. Yes, bunions can get worse. They do have crossover deformities, and they may have to have, as I said before, some adjunctive operations where we may have to do an osteotomy on the big toe to straighten it. We also may have to fix some of the instability of the hammer toes. And so there are certain other things. And I think every patient has to be evaluated. And we can't just cookbook and do everybody, but this operation really has helped give us the opportunity to give us a starting point to correct the straightening of the toe, and has helped that. So again, we're seeing these are some results at this gentleman 7 weeks, or this person. I don't know, I can assume it's a gentleman, but I'm assuming the left two are gentlemen and the right is a lady, but I'm not positive. But you see this person at 7 weeks post-op, this one at 12, and this last one at 6 months post-op with some very nice corrections. But again, everybody's results will vary. Again, we went over this as far as what to expect on the recovery. Again, every surgeon's different in his protocol, and some are more aggressive than others. And some patients are, honestly, my patients are going to push the envelope, and that's what we find. So again, insurances do cover this. Again, that will have to be evaluated by the office, and they'll do their pre-certs, but it is covered by Medicare. I think at this moment we are back to Derek.
Thank you very much, Dr. Rodriguez. Very nice job. We appreciate you, taking the time to diligently walk through that and just explain a lot of the active questions that are coming through. So we've had several questions come in this evening, and so we thank you for the great audience participation. We'll do our best now to answer most, if not all, of the submitted questions. As a reminder, if you have not yet, you can ask a question by clicking on the Questions tab in your control bar and typing it into us. Before I turn your questions over to the doctor, I'll start by answering a quick question, which Dr. Rodriguez did just address, but it has still come in a few times during the presentation. That is just a reminder that, yes, is the Lapiplasty procedure covered by insurance and/or Medicare? And the answer is yes. When the procedure is deemed medically necessary, insurance and Medicare typically cover the bunionectomy and joint fusion procedures that utilize the Lapiplasty system. If your doctor determines that the Lapiplasty procedure is right for you, he or she can reach out to your insurer to determine your specific level of coverage. So as we get into that now we'll start to kind of dive into some of these questions. And one of the first ones, Dr. Rodriguez, is one that we get quite a lot, and that is, can you do both feet at the same time?
Well, yes, you can. I do not. I think that, I think you're going to be pretty limited for the first 2 weeks, and walking in 2 boots. We're saying we're letting you walk at 2 weeks, but I'm not saying you're going to be running marathons at 2 weeks. So I think it really puts you in it's pretty debilitating to have it both done at the same time. So my recommendation would be to stage them. I know it's inconvenient to do 2 separate operations, but I really do believe that it is probably wise to do it in a staged fashion.
Okay, thank you for that. And another couple of popular ones that come through here is, how soon, assuming I get this done on my right foot, how soon after the procedure could I return to driving?
So obviously, if it's your left foot, unless you drive a manual, stick shift, then you could drive on your left foot immediately. On your right foot, when they talk about ankle fractures, it used to be, if you look at the study from JDJS and looking at just ankle fracture, not specifically bunions, but the ankle fracture was 9 weeks as an aggregate to when they could drive. Now, I do not recommend driving with a cam boot on. So typically a person would have to be out of their cam boot back into regular shoe wear prior to being able to drive. So I'm thinking you're probably looking at about a 2-month time frame.
Thank you, doctor. And this next one is a 2-part question. It's one, typically how long does the procedure take? And also, is it a local anesthetic or a general anesthetic that is used?
Well, so the second part first, I think as far as in my practice, I do a general anesthetic. I think that it is what we do in our surgical center, but we do a block for regional anesthesia to mitigate how much pain medication the patient will need. So there's a big thing about multimodal pain medication, and we try to do a block for the operation to decrease the amount of narcotic pain medication. Now, how long does the operation take? In my hands, it's the last one I did was under an hour, but it depends. I think it really depends on what are the other things that we need to do. What do we need to address in addition? But then, I can tell you that it's always, you can't say always, but I think, by and large, it's less than inside 2 hours for sure, but more likely it's about an hour.
Okay, and part of your answer there leads me to this next question. If I had other issues with my foot, maybe a tailor's bunion, or a hammer toe. Are those issues that you could potentially correct at the same time as doing a Lapiplasty procedure?
Absolutely. Yeah, you could definitely do it. It depends on what they are and what we have to do, but and that's why everybody is we have to take it on a case by case basis. And there are certain limitations onto how much surgery a foot can have at once. But I do believe that certainly if you had a couple hammer toes or a Taylor's bunion, you could certainly more than likely have those addressed at the same time. But again, it's all case by case basis. And, the last thing I want to do is something that's unsafe for the patient and cause them to have, undue risk for this afterwards from a wound healing component and those types of things.
Okay, thank you, doctor. This one's a little bit for clarification. During the presentation, you mentioned a 6 to 8 week recovery. Is that 6 to 8 weeks off of your feet, or is that just a total? Is that a 6 to 8 week recovery time until your back activities?
So according to my protocol, thank you for the question. According to my protocol, first 2 weeks you are completely off of it in a post-operative splint, which is going to be a plaster splint, and then we will bring you to the office. We'll inspect your wound. And if we're able to take the sutures out, we will. If not, we'll leave the sutures in and have you return in 2 weeks to have the wound looked at again. But at that 2 week, so 2 weeks after your index procedure is when I'm actually putting you into a cam boot and allowing you to weight bear in your cam boot.
Okay. Thank you very much. And this is a quick follow-up to when you talked about the bilateral or both feet procedure earlier. If someone needs to get it done on both feet, how long would you typically recommend they wait before getting the surgery on the second foot?
Right. So I think typically my recommendation is about 3 months, 3 to 4 months. I think you need a good leg to stand on, and you need to allow the body to recover. So usually it's about 3 to 4 months after the first operation.
Okay, thank you. Let's keep going. Great questions coming in, so we appreciate everybody submitting these. Let's see. Will I be able to wear high heels again after the procedure?
Well, the answer to that is that's probably one of the reasons why Lapiplasty, or Lapidus in itself, has gained popularity, in that you don't take away the motion of the MTP joint of the great toe. So you potentially could do high heel wear in the future. Now, cognitively speaking, we got to see if a person's really wearing anything greater than depending on the age, cognitively speaking, some ladies who are a little bit older may not be wearing anything greater than a 2-inch heel. But ideally, this will be something, yes, that would allow you to wear high heels potentially.
Okay, thank you very much. And this is a good one too. Can you have the procedure done if you've had a previous bunion correction on the foot before, but maybe the bunion came back?
Well, it kind of depends on the radiographs and what was done. And so we look at, so if you had an osteotomy, which is basically where you change the shape of the bone, it may not be appropriate to do the Lapiplasty, because if I had the bone changed in shape before, and now I'm trying to rotate the metatarsal back into position, I may be looking at the joint facing the outer toes, and it may, so that is a big of a challenge. I think again, this is something that as I gain more and more experience with this in the consultation of patients, I think I have to review the x-rays and the incisions on the patient and kind of on a case-by-case basis decide if this is doable. There are other operations that are possible, and Treace has made some wonderful instrumentation for other types of operations that we can do here. And so I think the surgeon's going to have to kind of take this on a case-by-case basis, and to kind of categorically say no, I think is probably wrong. But if the person just had a bump removed, if it was just a bumpectomy, I think that's probably something that you probably could do. But if they had an osteotomy where we changed the shape, I think that's probably one that would be a more challenge to do.
Thank you. And this one is after the surgery, and typically in your practice, do you recommend your patients, are they on crutches? Would somebody be on a knee scooter? How does that work for you?
Yeah, that's a great question. So I think one of the things that has changed my practice was the invention of this knee scooter. I think that is something that is very helpful, and they're very inexpensive. I actually have patients just get them online, and they're mailed to their house inside of 2 days. I think that those are very helpful. Now, I think depending on the age, I think it may be that, so the patient's going to be in a splint after the surgery. We would, I mean, so that some patients are too old for crutches and they are unsafe on crutches. The knee walkers helped in that patient population, or a formalized walker might be better from a standpoint, depending on how what the person's balance is and strength. That's where we might recommend a walker.
Okay, thank you, doctor. And this is a good one too. I think this is a common theme that people have from time to time. We have somebody on who mentions they're on their feet a lot for work. They have bunions, but their bunions are not currently causing them any pain at all. Would you recommend somebody, with bunions, but they're not experiencing any pain, to get the procedure? Or what would your advice be in a situation like that?
Wholeheartedly, without a doubt, I would not do anything to the foot as long as there was no pain. Because I can tell you is that we can, bunions historically have been very frustrating in that I can get a perfect looking bunion that still hurts, or I can get a bunion that looks, not so good, but the person doesn't have a lick of pain. But I know that I can tell you that routinely I go through this and I tell my patients, if it ain't bothering you, don't bother it. And that is 100%. I will have that discussion all the time with the patient.
Thank you very much. That question comes in a lot. So I think, the pain is always a good indicator. So thank you very much for that one, doctor. Let's see. How quickly can somebody return to working out, like lifting weights?
I think so. If we're talking upper body, I think they can probably go back to doing things relatively quickly. As far as leg curls and leg extensions, I think they could potentially do that. But to get to where you're getting on the treadmill or going back to squatting, I think that's probably a 3 to 4 month process.
Okay. What about if somebody had activities, would they be able to, if somebody, these come in from time to time, and I love how specific everybody gets, so thank you. Activities such as like skiing or ballroom dancing, would somebody be able to return to those sorts of activities?
Well, that's the whole, I hope, that ideally, yes. In the bindings in a ski boot, honestly, the foot really doesn't move, right? So, so that's probably a simple one. The ballroom dancing is probably more challenging as it handles the MTP joint of the foot.
Thank you very much. This is a good one for clarification. How soon after the procedure, and it's kind of two separate answers here probably, can somebody get their foot wet? We have somebody asking like, how quickly can I shower? And somebody else is asking, how quickly can I get back in the pool?
Yeah, so my take on that is if there are any stitches in the foot, then I'm, as far as getting in the pool, I'm not going to let you do that. Even in a chlorinated pool, I think that's playing with fire. As far as, some of our plastic surgeon colleagues may actually allow you to get the foot, to shower. And usually, so the first 2 weeks, I'm probably going to keep you, they're keeping the dressing on and putting a shower, a bag over the leg to shower. But but I would say that to get into immersing the foot, as long as you have any type of stitch, we don't want to give the bacteria any type of pathway to get into the foot. As far as probably at 2 weeks, assuming that you get the stitches out, certainly no problem. Even with some stitches in at 2 weeks, depending on what the wound looks like, we would allow them to shower.
Oh, thank you. That's a good one. And there's one I'm sure everybody encounters at one point or another.
Right.
Let me just go, if somebody is on a blood thinner, would there be any protocols if they were to be a candidate for the surgery? Would they have to stop taking the medication, or could they still be a candidate for the procedure?
Sure. That's a very valid question. And typically the answer, I mean, I'm doing this operation under a tourniquet. So, we have some, laterality with that. But typically we're going to want the person to be off of their blood thinner, or at least bridged to a different type of blood thinner. So if you're on something like Eliquis, we may want you to bridge to something like Lovenox. And then depending on what the reason for you to be on the anticoagulation, how safe, as your cardiologist said, that you need to be, how brittle are you? And, so I think that's all case by case basis, but we have to, and all these things are taken into account, but typically the answer would be yes. The short answer would probably be yes, but again, it really depends on which blood thinner and for what reason.
Okay, thank you. And then, are there many follow-up visits, or what does the post-op protocol look like for coming back to visit your office? Is that something that's required?
Yeah, well, so I'm pretty conservative, and I would say the first post-op visit is typically 2 weeks post-op, and we would look at the wound at that time. If we're able to remove the sutures, we will remove the sutures. If we're not able to remove the sutures, then I kind of pivot and give you to come back at 4 weeks post-op. If I'm able to remove the stitches at the first visit, then typically the patient will come back at 6 weeks, and then probably going to come back at the end of their global period from surgery. So that's typically the 3-month follow-up. And then probably you're looking at an annual basis, the first year. And depending really on how they're doing, we might actually discharge the patient at that point. But, I'm pretty conservative, and I may want to follow this, periodically on an annual basis for a little bit, just to make sure that everything's looking good.
Thank you. In regards to pain, you mentioned before, and you were talking about during the procedure. Do you perform a nerve block during the procedure?
So typically, we have our anesthesiologist do a regional block for the anesthesia. So in addition to putting you to sleep, they will do an ultrasound guided block in the preoperative area for the analgesia control.
Okay, thank you. Let's see. Any restrictions on somebody flying after the surgery, or does that come down to how long after the surgery, or maybe if they're still in a cam boot?
I think certainly. I think that is. If they're going to be flying afterwards, we may want to have them on an aspirin. A lot of times we're using aspirin as our coagulation medicine, we go to use, as opposed to using the Lovenox or anything like that, we've gone to using just aspirin. But if they're flying, we're probably going to want them to have some sort of compression sock and probably some aspirin. But again, I think it all depends on their risks. What are the person's risk factors for a DVT? And I think that has to be taken into account.
Okay. And how long until somebody, returns to work? Obviously it could be a desk job, or it could even be somebody who maybe is like a nurse who's on their feet a lot more. Would there be a difference there? Absolutely,
there will be a difference. Depending on what your foot needs to do. Now, is your employer, will they allow you to work in a boot? Anytime the foot's down, you have the possibility that the foot can swell, okay? And that may, in turn, you need to, the only way to get it better at that point is to elevate the foot. So I think certainly sedentary jobs will probably be easier for somebody to return. But again, it's still, the foot can still throb and may have to be elevated. But, and I think it really depends on what the level of activity that you need at your job to see how you would be able to return.
Okay, thank you very much. In regards to, I know we touched on this briefly during the presentation. You were talking about, how to determine if you're a candidate and obviously visiting a doctor. If somebody has diabetes, could they still be a candidate for the Lapiplasty procedure?
Well, yes. So I think that comes into, there's many different flavors of diabetes. I mean, I think that the most important number for a diabetic, in my opinion, is their hemoglobin A1C, which is a true picture of what their blood sugar is. And I think that certainly any diabetic is at risk for postoperative complications. But if their hemoglobin A1C is in the 6 or 7 range, that person's more like a normal patient than somebody whose hemoglobin A1C is in the 9 neighborhood. And it's, this hemoglobin A1C is a 3-month tally basically of what your blood sugar is in real time, and not what the blood sugar was when you crammed for the test and you did everything right and you went and took your blood sugar and on a fasting exam. I think that number, when I was in medical school, that number was, fasting blood sugar was like 143 or something. I think now that number is like down to like 120 something. But I think, in my opinion, the hemoglobin A1C is probably the most important. But so again, I think that it's not a contraindication to the procedure, but it could be a relative contraindication.
Okay. In a similar vein of questioning, if somebody is a smoker, would that affect them potentially being a candidate for the procedure?
Well, the smoking will, what nicotine does is it robs the small blood vessels and causes them to constrict, okay? So smokers have 3 times the complication rates of non-smokers, okay? So, and it really is important from the date of surgery going forward. Now, it doesn't mean that they are, not candidates. I still have many smokers. I live in Lower Alabama. We have many smokers, and but it's not a total contraindication, but it's just something that they have to be aware of, that they're playing with a little bit of fire, and in that they are, increased risks for complications post-op.
Okay, thank you very much. Here's some good questions still coming in, so thank you very much for everybody who's joining us still tonight. This is terrific. Is physical therapy required after the procedure?
I think we do have patients, but I think that's an evolving market there. I think we are, as we are being more cost conscious of our healthcare dollars, I think that we are looking at alternatives to therapy, and we may be where we don't necessarily, we don't necessarily categorically say you have to go to therapy. I think it all depends on what the swelling parameters are, what your gait looks like. Certainly I would not send somebody to therapy before that 6-week interval. And it depends. So by the time they come around to 6 weeks and they're transitioning back into normal shoe wear, they may or may not really need the physical therapy. So I think it really kind of depends.
Oh, thank you so much. Early in the presentation, you talked about the plates that are inserted into the body and the metal. Would there ever be instances where the hardware would have to be removed? Is the hardware designed to be permanent?
Well, there are, so, I mean, there is no, we don't routinely take this metal out. Now, some metal patients have reactions to metals, even though this is an inert metal. Some patients are hypersensitive to metal. Sometimes there's a thing where called a modulus mismatch, and basically where the metal, the junction of where the metal is and the bone, that junction of where it's laying on the bone, that bone wants to bend. And as we load the foot, there's some times where the metal will cause pain, or actually it's more of the interface between where the metal ends and where the bone starts, back where the metal is rigid and the bone wants to bend, and that can cause pain. So in that setting, we may consider taking it out. Certainly, we would hope that the fusion has taken before you would get to that point. But again, I don't think that this is a routine. These are all case-by-case basis on how the patient's feeling. There are, certainly if the bones don't heal, then the metal, as we said earlier, if you bend a paperclip enough, the paperclip's probably going to break. So if this joint doesn't fuse, now mind you, we talked earlier about this being a locking construct in 90-90 configuration. So it's a very stable construct where we put a locking plate. So there's the plate with 4 screws on the top, where all 4 of the screws lock into the plate. And then that's on the top of the bone. And then on the side of the bone, on the inside, we put another plate with 4 additional locking screws. And again, every one of those screws locks into the plate. So these things would have to fail in what's called catastrophic failure, where they would basically, the screws in themselves you may have had an ankle fracture in the past and one of the screws backed out of the plate. Well, this does not do that. It would have to back all of this whole chunk of bone would have to be removed. So there's some fascinating videos on that for when they introduced locking technology back when I was a resident. But not normally does the metal have to be removed.
Okay, thank you. In this one, we had a couple reach back out. We were discussing earlier the topic of pain in regards to, when somebody should or shouldn't get the procedure. And so a couple, people just asked if you could, maybe touch on that again. If someone's really not in a lot of pain, what should they do in regards, I think it was you mentioned, if somebody said they were not experiencing any pain whatsoever, you were recommending them to hold off. So would you mind touching on that topic again of, the severity of the bunion as compared to the pain that it's causing somebody?
Right. I mean, so again, if the person comes to me and their bunion looks terrible, because I have some ladies whose bunions look horrible, but they don't have any pain whatsoever. And they may be rheumatoid arthritis or something like this. But if they don't have any pain and they have a lot of deformity, I'm not going to recommend that they have a surgery done. So the bunion, so we're looking at, so we're looking at pain to be one of the main things, and then we're looking at deformity as well. So, and again, those bunions can go from mild to moderate to severe, depending on the angles and the how far the metatarsal is spinning out. So, but yeah, so it is. Again, I think I would caution anyone to having this operation done for a cosmetic reason. It is not a cosmetic procedure. It is an adjunct to a problem, and it is a very effective fix for a painful process.
Thank you very much. I appreciate you diving into that again. Thank you so much. Let's see here, going through some good questions still coming in. Let's see here. I know we had touched on this earlier, but we had some people joining a little bit later. And so they had a question. And the question is, if somebody has a hammer toe, or bunionette, are these items that could be corrected at the same time as doing a Lapiplasty procedure?
Sure. We routinely will do other procedures like the bunionette or the hammer toe when so we, basically what we've done, if you kind of look at, this picture where we have taken the big toe and taken it from being crossover on the next toe over, and we got it out of the way, well then, depending on whether that toe is rigid or flexible, will dictate whether you have what the surgery needs to be done to fix the hammer toe or the bunionette. So yes, we can certainly do some additional operations, but there may be a limit as to the amount of surgery that a foot can accept at any one time.
Okay, thank you. Couple topics coming in regarding scarring. And what should somebody anticipate in regards to scarring after getting this procedure done? And is there anything they can do to alleviate that?
Well, that is a great question. I think so. The procedure in itself, the Lapiplasty incision is on the top of the foot, and the incision is probably about maybe 2 to 3 inches long on the top of the foot. Then there is you have a alternate stab incision on the between the second and third toes. There is a possible additional incision on the medial side of the foot where the that compressor bumper goes. They have gone to the larger bumper, and we don't necessarily have to cut the foot at that level. Now, typically they do have an incision in the webbing between the first and second toe. And then they typically would have an incision on the heel for bone graft to help, because it's a fusion and we're trying to get this to heal. We usually use a bone graft from the heel to help the, kickstart this healing process. Now, if the patient has, if you're also going to do an Aiken osteotomy of the big toe, which is an additional straightening out of the, we bring the toe back and we may have to derotate the big toe a little bit through the small bone of the 2-bone construct of the big toe. We may make a correctional osteotomy of the big toe. And so that would be, usually 2 stab wounds on that. But again, a lot of these are, the incisions are basically the width of the knife blade and no larger. The biggest incision is going to be the one on the top of the foot. Now, how do you combat scarring? Well, some patients are prone to, keloids or large, painful incisions. That's, not everybody's the same. We would, whenever you have an abundant scar, I usually tell the patients is that it's you have to massage the toe, and it's the energy you put in to the collagen to help it reorganize. So whatever your product that you want to use, vitamin E or maybe a Mederma or something like this, it's really the energy that you're putting in to see how soft tissues get supple. And so I don't know if that answered the question.
Oh, thank you very much. Appreciate the thoughtful answer there. Got a few more questions still coming in here, and one that has come in that I always want to make sure we give you time to address is, if somebody's interested in learning more about this procedure and potentially getting it done, but they might not be from your area, do you accept patients from out of the area, from out of town?
Of course, yes. I mean, we would definitely, accept patients who want to come talk. We have a lot of, we're in the South, so we get a lot of snowbirds from, the Midwest who come and enjoy our beautiful beaches down here in Lower Alabama. So we would definitely entertain the opportunity to take care of patients from other areas. From my practice when I was at Tulane, I routinely have patients who come to see me from the southern Louisiana region. I had a patient last week who came all the way 4 hours away from Lafayette. So it is, it's very flattering to have patients follow me to that extent. And very humbling in that respect.
Okay, thank you very much. Let's see, we've got a couple more we'll dive through here. You mentioned early on, and something you may be asking for just a little bit of clarification. When you say weight bearing, and we talk about weight bearing in a boot, is that different than walking around just in your tennis shoes?
Yeah, so the boot is going to have a flat surface. So we're talking about a cam boot. So this is one of these moon boot looking things, and it's a flat surface that the patient can weight bear on. And then some of those boots will allow you to primarily weight bear through your heel versus being, but you don't want to put the stress on rolling over the midfoot. You want to allow this to heal. And so, but yes, we are encouraging the patient to weight bear to their tolerance of pain. And so some people are better than others at doing that, but we're definitely allowing them. Now, if their bone quality is poor, I may change that. So what do I mean by that? Was when I go into, if they have some touch of osteopenia or osteoporosis, and certainly those are tests that we would kind of have an idea as to the bone quality. But if I'm drilling on the bone and I find that the bone is like soft, and then I may pump the brakes a little bit on my protocol post-operatively. But again, it is pretty much routinely. I mean, we're allowing patients to fully weight bear in their boot, and that's as opposed to a tennis shoe, which the tennis shoe is going to be something that we're going to get to in 6 weeks. Now, you might be able to do something if you can fit your foot in a shoe because of the swelling. If you could fit your foot in the shoe, we may advocate that you get something called a carbon fiber plate, which would kind of work just like a boot, where it is a rigid piece of carbon fiber metal that you would put underneath the liner of your shoe. But the rate limiting step here is going to be, quite frankly, is that the foot's going to be too swollen potentially. People can have swelling in their foot after this, any type of surgery, up to a year. Now, it won't be as drastic as it, in the early months, but but yes, that's I would say that the rate limiting step would be being able to fit your foot into a shoe.
Okay, thank you. And this is one you just briefly touched on a little bit too. And if somebody has osteoporosis, could they potentially still be a candidate for the procedure?
Absolutely. I mean, I think it depends on what are they doing for their osteoporosis? Are they working with somebody in their bone health? And so we would, we have a bone health department in our office, and if we see someone who has multiple fragility fractures, we will routinely set them up to have their testing done. And then if they need some sort of medication, we would have our bone health department routinely get them on there. But again, I don't know that having osteoporosis is a contraindication to having it, but certainly it's something that has to be considered.
Thank you. And then lastly, can somebody be, or would somebody ever be too old to be considered a candidate for this procedure?
Well, that's funny. If I had been told when I was coming out of residency that I would be operating on somebody who was 85 and doing an elective operation on them, I think my boss would have strung me up. I think the 85-year-old today is not the 85-year-old of yesteryear. I think our patients are healthier for longer periods of time and staying more active. So I can have some 70-year-olds who look like 90-year-olds, and I can have some 90-year-olds who, quite frankly, are like 50-year-olds. I mean, so I think that is, not a complete contraindication to necessarily having the operation done. But again, certainly when mama goes to get evaluated, her son may come back and say, what are you doing? So.
Well, thank you very much, Dr. Rodriguez. So as we begin to wrap up now, if your question did not get answered, or if you think of something later that you wish you'd ask when you had the opportunity, I know that happens, please feel free to reach out to us. You can email us at patientinfo@treace.net. You can also learn more, again, or find a local doctor in your area by visiting our patient website, lapiplasty.com. And as a reminder, don't forget that we will be following up with an email to all registrants and attendees with an archived webinar link within the next few days for your reference. We hope that you found the information presented tonight helpful. Dr. Rodriguez and I appreciate you joining us. I'd like to thank you all for your time. And again, Dr. Rodriguez, thank you very much and a job well done. And I hope everybody has a wonderful evening. We thank you.
Thank you very much, Derek.